For every 3 people that will be diagnosed with cancer, 2 of them are likely to survive. But they're 70% more likely to have some type of a serious financial setback. In fact, cancer patients, there's 2.5 times more likely to have to file bankruptcy. So cancer is a very serious and life-threatening disease, but with it comes stress and oftentimes financial hardship for people as they undergo treatment for months and sometimes even years, even for those that are on Medicare. So in this video, I'm going to share with you the Medicare plan that I would not want to be on if I had a cancer diagnosis, so that you're aware of the problems and can avoid this plan. So we all know how devastating it would be to have a cancer diagnosis and also the financial hardship that can result with that. And so what we're going to do in this video is to make sure that we understand that when we go on Medicare, we're making a decision as to how our coverage is going to look if we get some serious health problem, heart disease, cancer, some respiratory issue, whatever. We know that the decision that we make about our health care coverage is going to determine where we can go and what it's going to cost us out of pocket. So all those variables are going to go into this. And so really that's what I want to emphasize in this video. So let's begin just by talking, first of all, just about some of the issues going on today with this, which is truly a cancer epidemic in our country. Number one, there are 2 million new cases every single year that are being diagnosed right now. Now, of those 2 million, 60% of those, so now we're talking 1.2 million people that are getting diagnosed with cancer are those that are already on Medicare. All right, number 3. Cancer is the second leading cause of death in the U.S. First would be heart disease, second would be cancer, and then third would be stroke, and then fourth would be different respiratory type of problems, COPD, emphysema, lung disease, those kinds of things. And then also what's staggering is to think about the amount of money that's spent every year on cancer care, $200 billion every single year. Now, what's interesting about this particular stat is this, that 42% of that amount of money, which should be what, about over $80 billion, is actually paid out of pocket by people that are diagnosed with cancer. I found this interesting statement. This gentleman wrote this article, said this: people often only think up to surgery, but most post-operative care is where the higher costs are. Dealing with complications and covering cost of scans, home care, and follow-up treatments such as chemotherapy is when it really gets expensive, to the tune of $200 billion every single year. Next, let's look at this. Let's look at the most common cancers that seniors are diagnosed with today. Top 4 would be lung cancer, breast cancer, prostate cancer, and then colorectal cancer. Now, what's also interesting about these is the amount of money that's spent for the average person's treatment on these. Lung cancer is huge right now. It's over $280,000 spent on the average person that is diagnosed with lung cancer. Breast cancer right now, the average is just a little over $100,000 per case. Couldn't find a number on prostate, but did find one on colorectal screening. This is interesting. Colorectal cancer, $165,000 spent. And so as we look at these 2 million diagnoses every single year, they take all the cost of that, and right now the average person that gets cancer, there will be $150,000 spent on their treatment. And keep in mind, 42% of that number actually could be subject to out-of-pocket expenses paid on their own. All right, so we all know it's expensive. All right, now let's talk though about what's involved in cancer treatment. If I get diagnosed with that, what are some of the possible services that I'm going to get? What's the cause of all these tremendous amount of costs? Number one, you're going to see probably several doctors to get the proper diagnosis, but then also the proper treatment plan, and then all the follow-up that's going to be involved as well. So primary care doctors, specialists, oncologists, also scans, CT scans, MRIs, PET scans, all those of course expensive. And then many people are going to go through surgery. Lung cancer may remove a lung. If you have any other kind of cancer, more than likely it is going to be removed if possible. And then all the hospital care that's involved with that surgery prior to and then afterwards. Chemotherapy treatment, very common today and also very expensive. Let me read this to you real quickly. This article states that chemotherapy is one of the most common cancer treatments. Depending upon the drug and the type of cancer that is being treated, the average monthly cost of chemo drugs can range anywhere from $1,000 to $12,000. It is not uncommon today for people to go through a series throughout a year. They go on to say if a cancer patient requires 4 chemo sessions a year, it could cost them up to $48,000 total. And so tremendous amount of money there being spent for chemotherapy. Very common treatment. Chemotherapy drugs. These are medications that are actually self-administered, that someone is taking on their own. Chemotherapy pills today. And again, these are very expensive. I saw a report on the top 5 most expensive cancer drugs right now being used. The low side of this, so this is monthly amounts, $15,000. On the high side, almost $100,000. So a tremendous amount of money for chemotherapy drugs that are self-administered. And then radiation treatment. Radiation, very common today. Right now, they're saying that it costs on the average person for breast cancer, radiation treatment is right at $8,600 a month. Lung cancer, $9,000 a month. And prostate cancer, $8,600 as well. And so just kind of give you kind of a summary of these different types of treatments. Immunotherapy, proton therapy. They say right now people that are undergoing this type of therapy, average cost $10,000 to $12,500 on a monthly basis. Okay, so average radiation, $9,000. Chemotherapy, somewhere between $1,000 to $12,000. Immunotherapy and proton therapy, $10,000 to $12,000. And then, of course, medications beyond just chemotherapy. And this would be for nausea type situations, other just ongoing medications that people need for other care beyond their cancer. Breast reconstruction, so someone has a mastectomy, a double mastectomy. Obviously, there's going to be some breast reconstruction that's necessary. That can be costly. Transplants occasionally are needed due to the cancer. Durable medical equipment. This is the equipment that's necessary for in-home type treatment that people have. Mental health services, because the mental health impacted because of the mental health impacts of cancer, clinical research, trial studies at times, cancer screenings that are ongoing, physical therapy, rehab, home health care. So they've been sent home after maybe a surgery or a situation where there's just ongoing home care. Obviously, those bills can add up in skilled nursing facility as well. And for people that do not recover, oftentimes are going on hospice. But here's the whole point. Lots and lots of services that someone is going to need for their cancer treatment. And so the question is, if we get diagnosed with cancer and we're going to need some of these things that are very expensive, what is our coverage going to look like when we're on Medicare? All right, so that takes us to our next slide here. And I want to really do a review with you and really talk about just choosing your coverage for Medicare, which could include cancer care if you were diagnosed with cancer. So when we go on Medicare, we really only have 2 options to use our Medicare benefits. We can enroll in the Medicare A and B system. That's the system that started back in 1965. And A and B pays decently, but A and B has some gaps. And we call those gaps or financial gaps. These are things that Medicare will cover financially, but not 100%. Medicare covers preventive 100%, but everything else, there's always a balance that a person has to pay out of their pocket. So there's 6 gaps. There's actually 3 gaps on the A of Medicare, which is the hospital side, and there's 3 gaps on the B of Medicare. So when we go in this direction and we enroll in Medicare A and B, because of the gaps, most people today are going to get some type of a supplemental plan, a Medigap policy to take care of those financial liabilities. And so the F plan, which is not real common today, people have them, but they phased these out over the last couple of years. F covers 6 of the 6 gaps. G covers 5 of the 6 gaps. And the N plan covers 4 of 6 gaps. And so when we buy a supplemental plan, we're actually paying a premium to cover the gaps. And again, most people can't get F plans today if you're born before January 1st, 1955, or started Medicare before January 1, 2020. You can still get F plans. They're not very a good value today, but they are available for those that were started their Medicare prior to 1/1/2020. After 1/1/20 start dates, people born after January 1st, 55, then the G plan would be the closest thing they can get to full coverage. The G plan covers everything, but the annual B deductible, in 2024, that is $240, and it's once a year. That's the G plan. The N plan covers 4 of the 6. It does not cover the B deductible, so you'd have to pay that out of your pocket, the $240 once a year. Plus, the N plan does not cover excess charges. Now, let me explain that real quickly. Excess charge means you've gone to a physician, a specialist, a surgeon, oncologist, and they will take Medicare, but they do not agree to take Medicare reimbursement rates as payment in full. They don't participate in the fee-for-service system as they're going to add add to the bill. And so when they add to the bill, that's 15%. And so if you had an in plan and you went to a provider that added to the bill, you would pay that 15%. Now, just so you know, it doesn't happen very often at all. I would tell you probably less than 5% chance that it would happen to you, but it can happen. And so if you did go somewhere and you had an in plan, you would pay the excess. And then every time you saw a doctor, you could be subject to a $20 copay. Went to the emergency room, you'd be subject to a $50 copay. So again, we have some additional out-of-pocket expenses, not crazy amounts. And again, we don't know about the excess. That just varies doctor to doctor. But these are the top plans that are available today. So when people go in this system, I'm going to show you why it is that I would choose this way instead of going with an Advantage plan. But when they go with this direction, they're going to have to pay a premium to do that. Why? They're transferring the liability of these gaps to an insurance company. So you transfer the liability, you got to pay a premium to them for them to accept that liability. That's the way all insurance works. But this is one option we have. Now, when I go this way, I'm enrolled in A and B. That means Medicare pays first. My gap plan is going to pay second. And then I also have to have a drug plan. So we actually add a drug plan. We call those standalone drug plans. Use these zip codes. Most zip codes have anywhere from maybe 15 to 30 plans to choose from. And there is a separate premium for those. Some of those are zero premium. Some are a few dollars. Average is about $25. But again, we have to have a separate drug plan. So that's one way I can use my Medicare coverage, and that's going to look a certain way if I get cancer. Hey, if you found this video helpful and you want to see more Medicare information just like it, then go below, right below the video, and you can give us a thumbs up as well as subscribe to our channel. And every time I put a new video, which is about 2 every week, you'll be notified of that video, and others just like you who need this vital information will get it as well. Now, the other option I have is to go with what's called a C plan. And what I have to do to have a C plan is I have to enroll into Medicare A and B, but that's going to then be replaced by a private health insurance company, C plan, also referred to as Advantage plans. Now, we use another acronym for these plans. We call these MA, Medicare Advantage, and that has to do with our inpatient and outpatient care. But in addition to that, many people will have a prescription drug plan added to their Medicare Advantage. And I highly suggest that if you have a Medicare Advantage, unless you're a veteran or retired military and have TRICARE for life, or retired civil service and have federal employee health benefits called FEHB. You can get your meds through FEHB, you can get them through TRICARE, you can get them through VA, and then you would not have to have a prescription drug plan. You would have what we just referred to as an MA only plan. So if you're not in one of those 3 categories, we're going to have MAPDs, inpatient, outpatient, and prescription drug all in one. Okay, so in this system, what happens is this is a private health insurance company. Now, I'm enrolled in Medicare A and B. In both situations here, I have to pay my B premium, which is $174.70 in 2024. That's what I have to pay to be enrolled in Medicare A and B. And frankly, this is the only item that these two systems have in common. You've got to be enrolled in Medicare A and B to have either one of these insurances. Okay, now I do want to clarify something. This $174.70 is the 2024 B premium. As long as if you're a single filer, your income is below $103,000, or a married couple at $206,000 or below, you would pay the $174.70. If you're above those thresholds, you pay an additional amount. I'm not going to get into that during this video, but those additional amounts are called IRMAs, income-related monthly adjusted amounts. And whether I have this system or that system, if I'm high income, I have to pay those IRMAs. Okay, so these are our 2 options. And what you choose is going to determine how your cancer treatment is going to go. The providers you can go to, your out-of-pocket expenses, that's going to vary. And so what I'm going to do next is talk about the difference between these and show you the plan that I would avoid if I knew I was going to get cancer. Now, I'm titling this particular slide, Concerns and Complications. When I say concerns, I'm just saying these are the things that I would be concerned about if I had an Advantage plan. And these are the complications that you may incur. Okay, and again, we don't know for sure what kind of cancer you're going to have, where you're going to want to go for that treatment, whether you're going to be treated or not. So those are unknowns at this time. But I can tell you about some of the complications of people that I have known that have been in this scenario where they had Advantage plans. And so what I simply want to do is not here to badmouth the Advantage plan, but to make sure that you understand that depending upon what coverage you have, whether that's a supplemental plan or Advantage plan, it is going to look different for you. All right, so let's let's talk about this just real quickly. We've said what these two have in common is I've got to be enrolled in A and B. That means I have to pay my B premium. So out of pocket, I'm definitely going to pay for that regardless of whatever system. Now, if I decide that I'm going to get a G plan, and again, I'm just giving you some rough numbers. We are a national broker. We write in all 50 states, and so these premiums vary throughout the country. But if I have a G plan, what's going to happen? I'm going to pay on average about $125 a month. Let's say I'm turning 65. That's going to be an average G premium, which means what? I'm going to spend about $1,500 a year out of pocket in premium alone. Right? If I have an N plan, those things right now, they're between $95 to $100. Let's just call it $100 a month. So I'm going to spend out of pocket in premium about $1,200. Now, in both of these scenarios, I've got to meet my B deductible, right? I got to pay that $240. Plus, if I have that N plan, I've got some copays. Remember, I've got to pay $20 to see a doctor, $50 to go to the emergency room, and I'm also responsible for excess. And you're going to save, again, $25, $30 a month or so. And sometimes people want to do that, which is certainly fine. But here's my point. If I go with the supplemental plan, I'm kind of prepaying. I'm paying out of pocket. I'm not going to have to pay a lot of things beyond these items right here. But if I take that Advantage plan, what's going to happen? This C plan, again, I'm still enrolled in Medicare, but the way this system works is it's designed for me to have pay as I go. I have copays. I have co-insurance. Sometimes I have a deductible. All right, so my out-of-pocket expenses are not premiums. They are copays, co-insurance, deductibles. So I pay as I go. Right now, I mention all this because a lot of people take C plans today because there's zero premium to the insurance company, which is attractive, meaning they don't have to pay these amounts here, but it's almost implied as though everything's going to be free, and it's not going to be free. And if you go through cancer, and we looked at a list that was just really not an exhaustive list of possible services, there were I think 18 to 20 items on there, you're going to pay for all those until you hit what is called the max out of pocket. So we pay as we go until we hit the annual max out of pocket. Now, the annual max out of pockets right now are going to be on the HMO plans. They're going to be anywhere on average of about $3,000 to about $5,000 for the year. If I have a PPO plan, that PPO plan is going to be anywhere from about $4,000 to maybe $7,000 out of pocket. And here's my point. So I have no premium to the plan other than Medicare, but I'm still going to pay. And again, if you're going to have cancer, you're going to have a lot of out-of-pocket expenses. They'll be reasonable, they'll be low, but they will add up. And normally, people that get cancer and get treated for it are going to max out a pocket. So what I'm showing you first is financially how this is going to look. You're going to pay out of pocket. Now, once you hit the max, you're done paying for the year, and then these max out of pockets reset every January. So if someone gets diagnosed with cancer mid-year, in the year, and they max out, which they usually do very quickly because chemotherapy, radiation, surgery, all those things are expensive, and they're still being treated, and these max out of pockets reset in January, they're back to paying again until they hit their max out of pocket. So it's very obvious. If I look over here and say, okay, in this scenario on my G plan, what did I spend? I spent for the whole year $1,740. And after that, I have nothing out of pocket. Medicare is going to cover everything on the in and outpatient care. If I'm over here, I spent $1,440. Plus, I had a few copays, but if I compare those out-of-pocket expenses to what I'm going to have on my Advantage plan, those are going to be substantially less. All right, so financially, there will be a difference. But I want you to know, I'll close with this. There is a bigger difference even than financial difference, and that is the kind of care, the options you have, and what that care is going to look like. Let's do a comparison there as well. Hey, if you've come to the place where you know you're going to have to make some Medicare decision pretty soon and you want to make the right one of the best ways to do this is to go down below, and you'll see in the comment section there, the very first pinned comment at the top. You can actually click on the link there and you will book a call. And you'll book a call with one of our Medicare guides. All the guides with our company, I have personally trained them. They're professional, they answer all your questions, and they'll show you your Medicare options so that you'll be confident in your decisions. Let's get back to the video. My first concern that I have with Advantage plans has to do with networks. Networks. So this means networks would be a network of providers, hospitals, doctors, specialists, oncologists, surgeons, all that. And so if I'm on an Advantage plan, right, I am going to select my network when I select my Advantage plan, and that's either going to be an HMO or a PPO network. Now, what this means is the HMO, called Health Maintenance Organization, PPO, Preferred Provider. It just simply means that this private health insurance company that replaced A and B for you is going to contract with different providers, and that provider is going to make a decision whether they will treat patients through that company's HMO or PPO plan. Now, the difference would be the HMO plans are going to have less options for providers. Now, I'm not saying there's not going to be plenty of options. I'm just saying there will be less providers on that HMO plan than on a PPO. The reason is because HMO plans do not pay the providers as much money to get services from the doctor, the hospital, or skilled nursing. And so you'll see it's going to be a much stricter of a network simply because they don't get as much money. PPO, you'll see more doctors willing to be in that particular network because, again, they're paid more money. Another issue with the HMO network is you have to stay in your network to get all your services unless it's urgent care or emergency room. Otherwise, you have to be in the network. If you go out of the network, HMO will pay nothing at all. They're going to keep you in that network. And hopefully, for the treatment that you want, you're going to be able to find a provider that takes that plan. I will tell you that some doctors will take both HMOs and PPOs. Some will not take the HMO because financially, and they'll take the PPO only, and there's some that take none of these. They're not obligated to take Advantage plans whatsoever. And so we're going to see some restrictions here in size and availability of providers. Also can't go out of network. Now, the PPO lets me go out of the network, but when I do so, it costs me more money. If I stay in my network, my max out of pocket could be $3,000, $4,000, $5,000 for the year. I go out, could be $10,000 a year. And so you're on a PPO and you get cancer. When you go out of the network, what's going to happen? It's going to cost you substantially. Now, as I make that comparison between the plan I would want to be on, which is a supplemental plan, so I'm over here now and I'm enrolled in A and B, and I get that supplemental plan. Remember, the F plan, the G plan, the N plan, those different plans. What happens is I can go to any provider that takes Medicare A and B. Because now the only requirement as far as networks is concerned, do they participate in original Medicare A and B? And I will tell you, 99% of all doctors do and 100% of all hospitals do. And so there's some docs that don't, but the majority do. In other words, if that provider takes A and B, they will take your supplemental plan of choice. Whatever letter you decide, whatever company you decide to go with, they will take that. Here's my point. I'm not going to have network issues over here. And if I'm going through all the host of providers and the list of all those care, I'm probably going to need multiple providers. And it may be very difficult to find those all in one particular Advantage plan network. I'm not saying it can't happen, but I think it's going to be difficult. So if I had cancer, what plan is going to look best for me as it relates to providers? I believe the supplemental plan is going to be the best situation for me. Now, the second thing that really matters is pre-authorizations. And by the way, this is something that a lot of agents don't talk about. And frankly, the reason agents really push Advantage plans is because Advantage plans pay us a higher commission. Now, if an agent cares about you, agents will talk about both. We do. We write Advantage plans, but we also talk about these and we talk about the differences because it's going to matter to you when you need your insurance. And so agents that care about commission, they only want to talk about Advantage plans because, again, we make about twice the amount of money on initial commissions, and they pay us a lifetime residual. So they're very valuable to the agent. But my concern is what's your care going to look like on that Advantage plan? Not my commission, but your care. All right, and so pre-authorizations can be an issue. What is that? This is a service that's needed that the doctor says you need a scan, or you need a hip replacement or knee replacement, or something that is more expensive, that the insurance company now has to give approval before you can get it, and they're going to pay for it. That's a pre-authorization. And so there's this process that is involved in getting a pre-authorization. And so the insurance company has the final say-so with the Advantage plan. Doctor says you need it, Advantage plan has to agree, or they're not going to cover it. And sometimes, folks, they will agree, and they will pay for it. But there's plenty of times where they will delay it, meaning they'll say, no, we don't believe you need that. We think therapy is sufficient. We think you ought to get this second opinion first. So there's sometimes that care is actually delayed for a time, and it can be a hindrance, especially with cancer, or it could be denied. They simply say, hey, we're not going to pay for that. We don't think that you need that, and therefore you're not going to get that. Why? Because the insurance company has the final say so. They tell us right now that 70 to 72% of the services that people need on their health care plan with the Advantage system, those are going to have to be pre-approved by the insurance company. Over here, never, okay? Now, I'm not saying Medicare does have some pre-authorization type things that happen, okay? But as far as the insurance company, that supplemental plan, they can never impose a pre-authorization. If Medicare says we'll cover it, doctor says you need it, it's going on the schedule, end of story, that supplemental plan is going to pay their part based upon the letter that you bought. All right, and then lastly, I want to talk about this, and that is permanency. Do you realize that in order for someone that has been on an Advantage plan for, pardon me, let's say a year, 2 or 3 years or longer, and they're on that Advantage plan, and they would like to get off of that Advantage plan and move over here to a supplemental plan, that they're going to have to medically qualify to be able to get a supplemental plan in the future? Now, the exception would be 4 states. This rule does not apply in New York, Connecticut, Maine, or Massachusetts. Those 4 states have open enrollment year-round. You don't have to qualify to get a supplemental plan at any time. But all the rest of 46 states and the District of Columbia, if you're on that Advantage plan and you've been on it year, 2, 3, 4, 5 years, 10 years, and you want to move over to here, now you have to go through medical underwriting. And if you have cancer, ongoing treatments, you're not going to get approved. All right? And so you could be permanently in that Advantage system, having to live with networks, pre-authorizations, max out-of-pockets every year, all those kind of things. But when you first go on Medicare, you have 6 months prior to your B date, not A date, B date. Once you've started the B date, we can apply in advance, and then on your B date, your supplemental plan can start. But you have the 6-month window of that B date where you have no underwriting at all. Those insurance companies are required to take you. That's called the Medigap open enrollment period, or the Medicare supplemental open enrollment period. Insurance companies have to write the policy regardless of your health conditions. But after that 6-month window of that B date, now you got to medically qualify to get that supplemental plan. And here's the whole point. If you buy a supplemental plan when you're first eligible to do so, either at 65 or at retirement, whenever you start that B date, that policy can never, ever be canceled on you. You have that policy for the rest of your life, even if you have ongoing cancer treatment and you never really fully even recover from that. You'll not get one anytime other than that 6-month window. So don't miss out on that opportunity. Yes, agents don't talk about it. Why? They're pushing this because of the high commission. But we want to make sure that you know that that Medigap open enrollment period, where you're guaranteed issue on that supplemental plan, is very critical. So these are my concerns and the complications that could occur if you had cancer while on the Advantage plan. So that's why I'm saying, if it were me, I would avoid it totally.